Let's start today. So with our review, this. So it's going to come part two. Remember, like Superman 3, 4, 5, 6. So this is Parkinson's part two. Today we learn. I just said my last name is supposed to be Parkinson. We have one doctor in town is Dr. Hand. Dr. Hand is a hand surgeon. I'm sorry, I know Mr. Parkinson's are just a Latino, Gonzalez, so that's fine. Okay, so let's start. So this is a very nice picture that we probably touched a little bit last time. So sometimes this is a continued process. Sometimes we got some people that start some constipation, many years having constipation. And when we had the first evaluation, they said, do you have any constipation? I know the tremors, but tell me about constipation. But these guys asked me about constipation because constipation could be part of the beginning of Parkinson's. So remember, that's the alpha-synuclein affecting the nervous system, the mesenteric plexus. People who have constipation is very common in Parkinson's. Many times I ask patients, you have constipation? They say, no, I have the opposite. And then tell them, actually that's the dream with somebody with Parkinson's. They usually suffer from constipation. So good for you, you have actually diarrhea. Then hyposmia. Hyposmia just means decreased sense of smell. So people say, why you ask me about the smell? It's a smell wrong? No, how you sense of the smell? So decreased sense of the smell is one of the motor symptoms that precede Parkinson's for about 10 years. So you say, no, it's normal for me. I don't smell. That doesn't mean it's okay. It's your normal, but you see the lack of sense of smell precede Parkinson for about at least 10 years. So that's one. And actually, it's as important is, well done in this article, somebody has no lack of sense of smell could be Parkinsonism. In the true Parkinson's, people have decreased sense of smell. In this article, we found, and actually one of my board questions, what the difference between the true Parkinson's versus Parkinsonism. So somebody, the sense of smell is still okay, but I said, probably you don't have the typical Parkinson's. Then after that, people said, okay, I feel some depression, and we have been talking before about urinary symptoms. So we see many people with Parkinson's have we call nocturia or polyuria. That means just waking up several times to go to pee. So remember, we have a lecture talking urology and Parkinson's. So some people need to go to bathroom 3 or 4 times daily at night, and sorry, or 5 times. So sometimes it's dopamine, and I give like a extended release and go for 4 times or 5 times you need to get up to 3, it's a winner. So you have an extra hour for sleep. So urinary issues could be part of the dopamine deficiency. And actually multisystem atrophy, we find people have some residual. You go to urologist and you know empty your bladder, that could be part of the multisystem atrophy. Not always is the prostate. And then we start with close to the diagnosis where you go into my office, oh, look at this, I have some tremors. That's, we want to start with the diagnosis. You say from the preclinical, from the non-motor symptoms, when this alpha-synuclein starts spreading, you go to the substantia nigra, in the midbrain is when people say, oh, look at me, I'm having tremors. That's the typical Parkinson's. But some people don't have tremors. And that's when we talked in the last lecture, we have different types of Parkinson's or subtypes. So we learned, and this article is very good about this, when people have tremor dominant of Parkinson's, is a better prognostication. Usually this type of Parkinson's progress is slower, and usually the progression is slower. There is another subtype of Parkinson's with people that have no tremors. People have more the akinetic, difficulty walking, balance, and gait. That is the second type, big type of Parkinson's. We usually progress faster, and usually reflex for this type of progression faster, it would be cognitive problems, REM sleep behavior, or having difficulty swallowing. So this is a red flag for me to say, okay, this patient is speeding up. The progression is getting faster. And we see some people getting the atypical Parkinson's is somebody, unfortunately, with a very bad dystonia, the neck, the posture we call the Pisa Tower syndrome. Some people don't have the tremors. They usually is not a good sign. You get your head like this, we call lateral colic, or people get bent over. A too much bent over is called cantochromia. It's more symptoms that the Parkinson's is progressing worse, faster, and could be a typical of the second type of Parkinson's. So you see this arrow right here, we get the diagnosis. You see, 15 years before, people got the prodromos of the non-clinical. And finally, people get with a little bit of tremor, or they start having decreased sound swing. So when in our first evaluation I asked you to write pentagons, and I always ask you to write this. Dr. G is giving me a hard time and I'm ready to leave his office. It's a long sentence. So you start with the big, and then the handwriting become tiny, 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 and very small, that we call micrographia. But you see in angioma resin, usually better than only the sentence, write 2 pentagons. That is more sensitive. And I said, I do my house, I do a big house, and they do small houses. I said, how come? I told you to do the same. I said, no, what's the difference? Most of the time they say, yours is bigger. No, you said, yours is smaller. And they said, no, but probably you have more money, so you have bigger house. No, it's not that. So that is called micrographia. That's part of the diagnosis of dopamine deficiency. So micrographia, decreased sense of smell, then we get the resting tremor or not, or the issue with slowness. We go step by step with the different symptoms of Parkinson's in a minute. Then you get the diagnosis, and then with the full Parkinson's syndrome. So Parkinson's is only no one condition, no one disease. It's a syndrome, it's a group of conditions. Different subtypes, different progressions, different clinical presentation, different genetics. That's that we're telling you. So let's go back again from the previous lecture. So subtypes could be just related with age. If you present with Parkinson's less than 40 or less than 50 years, we call young onset of Parkinson's. In that person in particular, I think more in genetics. If you are Jewish or you come from the Arabic, I had somebody with Arabia today, they are more common to have some types of mutations of the genes. So you have, we went to the genes today again, but the young onset, usually people get more genetic. We talk about mutations, could be sporadic. Talking about genetic, we call the Mendelian, this autosomal dominant or recessive, or it could be a sporadic mutation, so we talk about that. So the more we learn, we go from saying Parkinson's idiopathic, for saying we're getting more and more. So again, the medicine is changing. Before we go to the clinical, I suspecting, I thinking, versus getting biomarkers. We'll go biomarkers and genes, we get tell us more about Parkinson's. So that's for the age. For the presentation, tremor versus no tremor. Tremor dominant Parkinson's, better prognosis. No tremor dominant Parkinson's, gait and balance, instability, and worse prognosis, usually people don't better with medication, and usually balance. And then no symptoms, no motor symptoms. If people have from the beginning orthostatic hypotension or autonomic dysfunction, reflux, or the presentation, symmetric versus not symmetric. Let me stop that to explain that. Symmetric, that means people start with tremors in both hands. That is not a good sign. Parkinson's, for definition, the typical is asymmetric. That means it's starting in only one arm. You see, my tremor is starting in my right hand or my right thumb, and I see people in my, and I see, okay, you have a sense of tremor, but what happened about that thumb? It seems to be the Parkinsonian. So how come you know you have Parkinson's? Just with that, it's possible. So we got the biomarker, we do the DAT scan. So you have tremors on both sides, you know the good sign from the beginning. If you come with problem with the cognition first, then I see probably you go to the Lewy body dementia. The dementia and Parkinson's, they're a lot later in the condition. You start with the tremor, and later on time, you can go with the cognition. So you have dementia or psychosis. But you start with the dementia or the cognition first. Again, it's the atypical. And then you start with more hallucinations. Then I was thinking about Lewy body dementia. And later on time, these people with cognitive problems can deal a little bit of flavor of the Parkinson's. The same with the blood pressure or orthostatic hypotension. Later on time, it's very common for you guys to start developing orthostatic hypotension or blood pressure going up and down, but that's the first thing from the beginning. Many times, people come to my office complain of issues with getting dizzy when standing up. And then we do the blood pressure, we're lying down for 3 minutes, blood pressure, heart rate, then ask him to sit up, 3 minutes, blood pressure, heart rate, and finally, we ask them to stand up for 3 minutes. So if the blood pressure drops from lying down to standing up for 20 points in the systolic, and the diastolic about 10, and the heart rate does not compensate, is that we call orthostatic hypotension. But that's a problem. Sometimes it's not orthostatic hypotension only. The blood pressure goes up like this, up and down. So I want patient that in the morning the blood pressure is too low, but at night the blood pressure is bonkers very high. So they say, how I manage that? It's very difficult. And that's why people feel dizzy. It's like you go to Orlando, a roller coaster, up and down. How you go after that, you get dizzy. So that's the brain. The brain doesn't like that. So the brain like the blood pressure always the same. No matter you're lying down, sitting or standing, you have receptors in your neck, that the baroreceptors, that sense they change the position. Just sitting or standing, the blood pressure has a tendency to go down, there's gravity. So those receptors in your carotid arteries tell the heart, okay, you have to pump harder, otherwise the master will be upset. If that doesn't happen on time, that many times you stand up and start feeling dizzy, take a time, 2-3 seconds, and then you go, okay. So that's from the presentation, motor, no motor, age, and tremor or no tremor. You see, this is a very nice picture to see from no diagnosis or prodromus versus the progression. In some point, unfortunately, again, one thing to consider or remember, you are more in risk to have dementia. So it's very important. We talk about exercise here, physical and mental exercises. And if we forget, pun intended, you have to ask me, okay, my memory is not good. So let's do a MoCA testing. MoCA is no coffee with chocolate. It's Montreal Cognitive Assessment. This is a small screening. And now again, we have memory clinic and intercostal. And now we can actually, before get the testing, we can actually tell you you have Alzheimer's as well. Now we have 2 tests, we're getting better and better. So we have biomarkers in Alzheimer's, hopefully soon in Parkinson's as well. But we have the phosphorylated tau 217 and the ratio with the beta amyloid 42. And that ratio has to be, listen to this, I know it by heart, I'm not resting again, and you're tired of this, but it is 0.00317. Less than that, you're good. It is between 0.00317 and 0.00737 indeterminate, but you are more than 0.003737, you have Alzheimer's. That's a blood test. So we have that available. So the future of medicine, again, is biomarkers. You are in the more than 50 years, the future will be you have to have your screening for Alzheimer's. Blood test. Go across the hall, I write in a stat, and we only not do the blood test, but do the genes. There are 4 genes now for Alzheimer's that we can identify, E1, E2, E3, and E4. You have 1 copy of each of your parents. So the E1 or E3, and you have the 4 one is bad because the one can make you bleed. And we are that advanced and tell you this because we had in Alzheimer's now, and it's happening. And we have 2 medications covered by the FDA, that approved by the FDA, Kisunla and Leqembi. Soon, hopefully we can say the same for Parkinson's. We are in trials for that. But you know, Alzheimer's, unfortunately, is the first neurodegenerative disease around the world and the States, and Parkinson's is the second one. So what is the one we do more research, the more one is more prevalent, which is Alzheimer's. And unfortunately, and I have to tell many times, sometimes the fact you have Parkinson's doesn't exclude you to have Alzheimer's. Unfortunately, for example, today I had to have the bad news, somebody with Parkinson's will have Alzheimer's. So that doesn't mean you are out of the woods. So the way you do genetic, the physical exercise, your cholesterol, all these can delay the things, but now, as a preventive medicine, you have issue with memory. I'm very afraid to ask myself because my father have Alzheimer's. It's very common. So they're saying like you get to the age to 60 or something like that, they tell you have to have your colonoscopy or you have this and this preventive medicine. So don't forget about that. So we get in one of the main things about the lecture today. We got from the clinical and suspecting, or maybe you have this. Like remember, I always tell my patients, it's like back in the day, say, oh, I'm probably pregnant. Let's see. No, I'm not pregnant. Oh no, I am pregnant. Or you have Alzheimer's, or you don't. Or you have Parkinson's, or you not. It's a biomarker. It's like back in the day, 2019, 2020, I was talking a conversation. I start coughing. And say, oh, you have COVID? No, I just have a problem. Or really, you feel bad. I do my testing, and I have COVID. Biomarkers. So that's very important. That's how medicine is changing right now. Not talking, we have been talking about artificial intelligence is helping with all the diagnosis. Okay, so let's go to, we just talked about these things and we got the first slide. So let's go step by step with the different symptoms of Parkinson's. Let's talk about the motor. So we talked the no motor, let's talk about the motor symptoms in Parkinson's. So the bradykinesia. Brady comes from the Latin slow, and kinesis is moving. So bradykinesia is one of the symptoms of Parkinson's. That's why I ask him to do like this. So you do like this, and you do very fast, and tell you, what? You are like my Mexican cousin, like a Speedy Gonzalez. That means good. But you are slow. Okay, so I start suspecting that probably you have Parkinson's. The bradykinesia is one of the main symptoms or signs of Parkinson's. So other things that look a little decrease in the facial expression. If I see you in the clinic and see like this, and you feel like sad, and see one side different than the other side, that decrease of facial expression could be, again, one of the signs of Parkinson's. Sometimes some people say, oh, this guy is depressed. That's, yes, you notice any change in facial expression? They, no, he's fine. I look and say, no, probably he does. I'm sorry, and tell you probably. And then I ask him to speak. I speak so like this. I say, I'm sorry, I don't place my hearing aids. Please speak. I speak a little louder. And then we go from big and loud. So it's very common in Parkinson's. People start speaking soft. And most of them, my patients have a hearing aid. They say, no, I'm speaking fine. And they speak louder. I go to hear my hearing aid. And that's actually one technique that the speech therapists do here with people with Parkinson's. They place a device, like a headphone here, and then place like a sound, and that way people don't hear, and they have to speak louder. It's one of the techniques. Or we have the LSVT, the Lee Silverman voice therapy, that the speech therapists use in Parkinson's. So it's the big and loud program. So the hypophonia is, or speaking soft, the volume low is part of the Parkinson's. Then the decrease of facial expression, gesticulation. So the expression, most of the time telling people, please smile for me. Some people, this doctor very, very annoyed to me by asking, please smile. You have to smile. You have to tell your arm to swing. You have to speak loud. And that's part of the Parkinson. And sometimes they get annoyed. I'm telling you, and you're not doing it. It's because you don't have dopamine and you don't do naturally. So you have to tell, your brain had to command the arm to swing. Your brain had to command your voice to speak louder. Your brain had to command and make you smile. Because you don't smile, you feel like this, and that's part of the dopamine deficiency. So the small handwriting, we talk about that. We talk about difficulty turning in bed, which is very common, and it could be one of the signs of wearing off at night. You have difficulty turning on, and you're taking the carbidopa 3 times daily. Said, why are you taking at night? I don't have tremors at night. Why are you giving medication at night? Because you're wearing off through the night, and people taking, for example, carbidopa at 5 p.m., the last one, or 6 p.m., and the next one with 6 in the morning. Guess what? 12 hours of gap, and people will have difficulty turning in bed, and people have more, they wish to go to the bathroom. So you take an extended release at night, probably better turning in bed, and less frequency of urination or getting up at night. So it's a winner, and then people get cognitive better, more refreshed in the morning, and not too sleepy during the day, because then I'm sleepy. We have to look about the sleep, no mention about REM sleep behavior, and so on. So as well, we ask him to do the thing I asked him to move, and usually people try to beat me and then do like this. Okay, so that is speed. I said speed and amplitude. So you have to do big and fast. People do not, oh, no, you're fine. No. If I do big and amplitude, no, you definitely have bradykinesia and your speed is slow. So a speed of the movement is slow. There's with the UPRS, the different, they usually people do like this. Oh, no, you're fine. No, please open all the hand all the way and do like this. And then, no, you definitely do it slowly. No, doctors, I have arthritis. I know I have a trigger finger. Always there's an excuse to say, no, I don't have Parkinson's, right? But unfortunately, that happens. Okay. Okay, let's continue. There's only one is into rigidity or co-willing. So it's very common to people be stiff, but with the typical in Parkinson's, you remember the old German wood clocks that have wheels. So you just move it and stop, move the wheel and stop. The same with Parkinson's. We have to be loose like a goose, but doing the movement yet move and stop, move and stop. That's the co-willing rigidity in Parkinson's. Oh, in the presentation for Mr. Parkinson's in the 1890s, he described the pipe-led rigidity. The increased tone, so it's not only that the co-willing, you see the muscles are stiff. You touch it, the tone is, you touch the muscle, it is in rest. It's not totally flaccid. It's not flaccid for polio, but you have a stroke that will be increasing tone. But I hear in rest, my muscle is not too flaccid, it's not too hard, I have to have a tone. We call increased tone, usually people with Parkinson's, the tone, you touch it is a little increased. People call it like racket-like resistance, or some call it the lead type rigidity. Okay, and the resting tremor. So we're going to the co-willing rigidity, just mentioned that to you, the co-willing. Let's go for the tremor. So this is very important because back in the day, my training, I said, either you have Parkinson's or you have essential tremor. Sometimes you have both, or exposed with one or the other condition, you have a flavor of the other tremor. So in that review, next time, we're going to talk about essential tremor. Some people with essential tremor, for definition, is going to be postural tremor, postural, and action tremor. That's essential tremor. But I notice in many people, when I'm talking about essential tremor, I notice a little resting tremor as well. So we found in our reviews, again for the board, and I usually very, that no, you have one or two or both. Some people with essential tremor have a little resting tremor and never develop to Parkinson's. So I keep an eye, sometimes I do the DAS scan, and vice versa. Some people with Parkinson's can have some things that can look like essential tremor. So we do the review with Lauren this week, and you see people with tremor, for example, in the lips. It's very common in Parkinson's, but it's a resting tremor. So the lips is moving, while in rest, but asking to speak, goes away. But in people with essential tremor, that tremor in the lips and asking to speak actually make it worse. So that's essential tremor. You see, it's not black and white. It's difficult. And sometimes it could be the combination of both. For example, you can have Parkinson's or Parkinsonism and tremors, and little tremor here, but the main issue, the balance, that could be multisystem atrophy. So again, it's different syndromes, different conditions. So we're learning more and more. I know that I'm going to be right or going to be wrong. Usually the time unfold the truth. So you continue 1 year with the same tremor in the thumb, even you have essential tremor and never have another symptoms. That's just the essential tremor with mild resting tremor that can happen in essential tremor. So the tremor for Parkinson's, as you see, is 4 to 6 hertz. So 6 times per second the tremor is there. And that's this high frequency, low amplitude tremor, that's the tremor for Parkinson's. You have a tremor that is 12 hertz faster, that's more essential tremor. It's an action postural tremor. You have somebody here, and tremor is more like this high amplitude, high frequency, that's more essential tremor. Versus in Parkinson's will be less like that, and usually it's more the interphalangeal joints like this, and essential tremor is more the wrist. You see? The small details, but very important. Okay. So let's continue with that endoscopy examination. That's when you come, I ask you to place your hand like this over the knee because the examination, the patient we call supination. So we talk anatomical, this is supination and this is pronation. So I seem to be in pronation and hanging there, and that's when you see the tremor. The tremor like Parkinson like this, the tremor for essential tremor will be more like this. And I go asking to do like this positional tremor. Parkinson's, no, we tremor there. And it is Parkinson, they will play doing something more like this. You see the difference? This is essential tremor. This is Parkinson's. Okay. So let's go for the gait. When people start coming to the clinic, I actually to walk and I see somebody's not swinging one arm and have the tremor like this. Oh, okay, probably have Parkinson's. So decrease and swing and emergent tremor versus people working with essential tremor, the arm swing is okay, and then I send to place the hand like this and doing only action tremor. So that's very important. So one of the main features of Parkinson's, while walking, we see the decrease and swing most of the time in one arm. It's in both arms already. Either you are in the stage 2 of Parkinson's or it's on the atypical Parkinson's. And we won't make it to walk. We talk about the posture. So the posture, we see the stool posture. The people know it's because I'm getting old. Yes, we give you that. We're getting older. You can get kyphosis or more, but you're getting more and more and more and more. The people get like this. That is called xanthochromia. Is when the stool posture is very bad. Or people can get like one side like this. When you get in the stony posture like this, we call the Tisa Tower, talking about Italy, the Tisa Tower syndrome. Or people can get like this. We call enterocolis, so head drop. Or people can go in like this. We call cervical dystonia. That can happen in Parkinson's. And I had somebody with the arm, only the arm getting like this. I had something like this, like having a stroke. So getting Botox injections, and that usually is usually they don't do well with dopamine. Sometimes people with dopamine deficit dystonia. I have one patient, they come and having dystonia. She looks like having a stroke. I give you the dopamine, and now she works fine. And finally, she developed the typical Parkinson, more the resting tremor. So again, we don't have diseases, we have patients. Some patients can have essential tremor, Parkinson's. Some people, unfortunately, develop Alzheimer's. Or some people are doing very well and keep it with the Parkinson's very mild. Okay, so what the motor symptoms that happen in later stage? I just talked a little bit about that. The postural alterations, the trunk bend forward, we call, or lateral, I call the PISA. You see, it's not invented, it's there. The PISA tower was there. So it's the PISA syndrome. When you go to anterior, we call the xanthochromia. You see the spelling of that. Deviation of the trunk to one side to another. The head flexion, called the head drop. And then we can see in the hand as well. Or some people get, with Parkinson's, only get some dystonia. It's very common walking and the toes getting crawling like this. Sometimes medications like even amantadine, long-acting Gocori can help. Sometimes we had to go Botox, or sometimes, I hate to use this medication, but sometimes we have to use something like Artane or benztropine, and sometimes works, and sometimes nothing works. Freezing gait. So patients start working and finally get stuck. Freezing gait, again, it's a sign of the Parkinson's is progressing, more motor fluctuations. And usually, you go to a narrow space, they go towards the door, people get more stuck. So why we ask you use the laser input walkers in your houses is important to avoid a lot of stuff. Less stuff better, because otherwise you get the carpet or a small table here, you get and that visual input make you stuck. So the less clutter, the better. So narrow spaces. Some people actually make like a zebra, so then they make a line and make like one step in between, like with tapes, like blue tapes in those narrow spaces, and that helps. Oh, I have one of my patients, actually, he was instead to get this walker with laser input, which is very expensive, he bought one of the lesson input and he placing himself in his walker and it's working. Or you can use the lesson input and you cane as well. So this input helps. So balance alteration. So Parkinson's essential tremors usually produce imbalance. So that unsteadiness, many people come to my office, dizziness. So what dizziness? You feel lightheaded or you feel like a spinning? No, I just feel off of balance. The off of balance is very common in Parkinson's. So there is no such a thing like a pill for balance. The only thing that helps the balance is physical therapy. That way you have here Tai Chi, boxing, ping pong, uh, pickleball, tennis, all of these improve your balance and coordination. Dysarthria or dysphagia. So normally the boys get a little soft. Some people get, I have an excuse because I'm not from this country, so I had that accent issue with that. But people get very dysarthric. It's very difficult at some point get, not only the boys become to be soft, but dysarthric is very difficult to understand. And sometimes start having with drooling and then start difficulty swallowing, we call dysphagia. So that's very common in Parkinson's. So one of the red flag for me to know people are going to have difficulty swallowing, so I start having some drooling. And sometimes we have drooling at night. It's okay when we go to very deep sleep. Usually we drool a little bit, but drooling constantly is part of the progression in Parkinson's, one of no motor symptoms. And it's not like, sometimes it's not like you produce too much saliva because difficulty swallowing, you not doing it or you forget to do it. So it's important for you guys to remember, if you have this problem, to remember, okay, it's 1 hour, I had to make the exercise to swallow. Let's do it. Okay, I swallow. But you don't do it, that saliva accumulate in your mouth and then start getting outside. And some people getting too bad, we can provide injections. It's very common in the clinic, I provide MyoBlock injections. The MyoBlock is similar to Botox. MyoBlock is botulinum toxin type B. Botox is botulinum toxin type A. That's the wrinkles I we're using as for migraines. Occasionally we're using for this, but people with hyperhidrosis, meaning sweating too much, we can use as well Botox or MyoBlock. People come to my office saying, okay, I prefer to take a pill. So in Parkinson's, it's a no. I know some nurse practitioners doing it. I said, no, don't do that. Because usually use like atropine. You know, atropine can definitely help. But atropine is one of big medications we use with people in cardiac arrest. Or people will use glycopyrrolate. Glycopyrrolate as well is a tablet we can use. But they can produce constipation. You know, be a happy camper, no saliva, but now constipation. No saliva, no poop. Which one is worse? Both, right? So they can dry out, so I don't recommend that. So basically, you have difficulty swallowing, you start with speech therapy to avoid complication, especially multi-system atrophy. Use the straw, the chin down, and thick the water. Remember, one of the things is more difficult to swallow, we think around the other way, is the water. What is, because it's that thin, they can go to the wrong way. They give you aspiration pneumonia. So you can get something in the pharmacy, it's called Thicket. It's a powder that you place in the water, or you just do the smoothies. We're in the era of the smoothie, where it's fancy, okay? You place my banana, you place some things, and it's a little thick, and it's better. You can, and actually it's very nutritional for healthy. We're in the era of the smoothie, so you can use that. And then you have more difficulty swallowing, then you see the speech therapies. You can get a barium swallow study, and depends on that, we can decide this from the oral phase, or it's coming from the pharynx, or it's from the esophagus. Many people get in a scope, I had like narrowing of the esophagus, and they need dilatation, or you have hiatal hernia, or it's a problem with the stroke or something else. So that is dysphagia, difficulty swallowing. Okay, so what is the no motor symptoms present the early stage? So actually, we're getting better and better with biomarkers, and actually there is in the University of Pennsylvania, they developed a test, and it's very sensitive. Now we can make the diagnosis in people with family with Parkinson's with just testing your sense of smell. So there is a Pennsylvania smell test, and that's one of our question as well. How you distinguish somebody with true Parkinson's versus not? The people with Parkinson's most of the time have decreased sense of smell. Some people with atypical, they don't have Parkinson's. How distinguish Parkinson's with no Parkinson's? There is some people with alpha-synuclein versus some people have more tauopathies, meaning the tau. So somebody with supranuclear palsy or somebody with corticobasal degeneration, their normal protein is the tau, versus somebody with Parkinson's, the alpha-synuclein or in multisystem atrophy will be alpha-synuclein. So you with the biopsy, we can one protein or another. So we get the diagnosis, biomarkers. You say, okay, Dr. Gonzalez, we don't need you. I got my biopsy and that's it. I got the diagnosis. Okay, so the sense of smell is come at least 10 or 15 years before you start having the tremors. So how much we said sense of smell, they said reported in 70% of people, and they are formula testing, but most about 90%, and it's true. When I see most of the people first visit, you have decreased sense of smell, 90% around that number, and that's what they report. People say, yes, I had decreased sense of smell. Very rarely people say, no, my sense of smell is fine. And we see, and the wife said, the sense of smell is not good. Okay. So I just mentioned to you the University of Pennsylvania had this test, the sniffing stick test, which is, I have been a lot of research about that to make early diagnosis in Parkinson's. So you have family history. One of the very easy screening tests is the sense of smell. Sleep disorders. So it's baking Parkinson's. You sleep too much during the day, or you don't sleep well at night, or you have REM sleep behavior, or you have very vivid dreams. And we had this before in another lecture. Just today, I had somebody I prescribed pramipexole, and he got bad REM sleep behavior, and actually he was hitting his wife. And then we had to discontinue pramipexole. So I explained this, and I want to repeat this. We mentioned this in the last lecture. What is REM sleep behavior? So we go from a sleep for very light, then you went phase 1, phase 2, phase 3, phase 4, and finally you have to do the REM sleep. So REM sleep is you just dream. Actually, you're supposed to dream. I just watch the movie. Just start moving the eyes, so we know if somebody's sleeping very nice, and start dreaming. You see the eyes start moving like this, like that. And then you're supposed to. We usually people with not this condition, you are paralyzed. So you watch the movie, but you don't participate in the movie. People with Parkinson's or especially body dementia, they don't paralyze anymore. They get into the TV and start fighting with the gladiator, or somebody's attacking, and then they start screaming, and it's very real. It's somebody attacking yourself, and then you start kicking and screaming, and sometimes this could be the reason for people to separate beds or actually divorce. You get it? Yes, and don't people don't believe, I have a black eye, what's my husband? He's abusing. No, I swear I don't know. And it's true. They don't know. While we're sleeping, we don't remember. Sometimes, if we're dreaming, not having REM sleep behavior, I'm in the middle of the dream and somebody wake me up, I get very upset. Probably the movie was good, right? Or probably with bad. But you were in stress with that movie. So some people start laughing or start shooting. I don't know, you probably tell you can, if somebody want to share your experience, would be nice. So again, punching, shooting, laughing. So that usually we have REM sleep behavior could be one thing as well, no biomarkers, but some of the signs, and sometimes it's no good prognostication, people having that or progression, or it could be, it's very common in Lewy body dementia. Or if you don't have REM sleep behavior, and then you suddenly start having that, it's a sign for me to say you start progressing. Is one, okay, there's one red flag, the speed of the progression is getting faster. Now, let's go talk about the neuropsychiatric features. Some people feel like, and again, the facial expression, sometimes you don't feel facial expression, you feel like you are apathic, or you don't care about it, or is that you're depressed, or just your facial expression. So, unfortunately, with Parkinson's, it's very common when you're getting good enough, meaning the dopamine is there, you can feel depressed, or you can feel depressed about everything. You feel depressed that your condition is progressing too fast, or you can feel depressed that you get no improvement with the medication anymore. So that's why exercise is very important. You do exercise, you produce your dopamine, At the end of the day, what makes you happy is dopamine and serotonin. So instead to take too much serotonin, and people they say do the cocaine, all this stuff because they increase dopamine in your brain and serotonin. So instead of do that, which we definitely not recommend, is come here, do your physical exercise. So that's why you feel well, great. You do have a plan for exercise. After you do exercise, you do regularly, you feel great after doing the exercise. And when you don't do it, you don't feel well. And you feel like you betray yourself. You don't feel well. So it's something we call anhedonia, like people don't like to do anything. So if exercise doesn't work, and at some point we need to do something, we can talk about it. But definitely, people get to very bad depression, and then and I talk to my residents like, well, many people get into psychiatrists with bad depression. They start using something like Abilify or Zyprexa, and we went from Parkinson to tardive dyskinesia. So it's very important from the beginning. You have anything or you prescribe something for depression, double check with me. Because sometimes it is very bad depression. It's very easy to use something like Abilify, like Abilify, Zyprexa. Some people get haloperidol and get from one problem to another. And actually, all those medications make your Parkinson's much worse. Depression better, motor much worse. What about urinary urgency? We just talked about that. Incontinence, unfortunately, can happen. You can use the pens. You can see the urologist. If you are a male, we have to be sure there is no issues with your prostate, or you have status post-prostatectomy. Unfortunately, we get robotic surgery. Unfortunately, we damage the nerves that control the bladder, so the incontinence will be a problem, as well as sexual dysfunction. We very shy in Parkinson's. As a patient of the caregivers, we don't talk too much about sexual dysfunction. That happens. Unfortunately, it's part of the motor symptoms. And getting to the prostate or getting surgery, that can make much worse. Or getting as well, trying to get one problem can make things worse. If people have essential tremor and have Parkinson's, I give you propanol, and you're very shy to tell me, doctor, I have erectile dysfunction. It's not working anymore. Why? Propanolol can do that as well. Medications can produce that. So you have to be, but as well, you smoke, you drink alcohol, or you have diabetes, erectile dysfunction. So you take your chances. Drink more alcohol, you think what happened. Okay, orthostatic hypotension. We talked about that earlier or later in time. Autonomic dysfunction, blood pressure can be low when we're standing up or go all over the place. So the orthostatic hypotension happens first before any Parkinson's. That could be part of dopamine deficiency. That could be, we can do that scan. When I make my diagnosis with the first patient with dopamine deficiency and orthostatic hypotension, they're looking at me like I have two heads. I ordered that scan. And she was part of our intercostal employee, and later on time she lost some symptoms of Parkinson, and she's now in treatment medication for orthostatic hypotension. So again, this is more atypical. So there's no one Parkinson's. Heat intolerance. I had somebody, they come to me that she complained of heat intolerance. So I tell you, how's your thyroid? The first thing you're thinking, it's possible your thyroid is okay, and probably you have hyperthyroidism, and the thyroid was fine. And then we did the DAT scan, and the DAT scan was positive. Let's talk about the cognition. So, pun intended, don't forget about cognition, because most of the time we're thinking about the tremor, the gait, medication, but we forget about cognition. So it's very important from the beginning, be more physical, mentally active, be proactive to start reading different things, get a new hobby, and I'm glad you're learning Spanish. We can come next time. You can do all the lecture in Spanish. So this is great. So you have to teach me something new. He said, Dr. González, hola, ¿cómo estás? Ya no soy gringo, soy totalmente hispano. Háblame en español. Oh, great, good. Teach me, correct my English. This is a stereo two ways. So you have to learn my language, and then you understand me better. Okay, so attention disorder. So all the cognition, and again, we go from the clinical, and now we can make better diagnosis with, hopefully in the future, we can make the diagnosis of Parkinson's dementia with biomarkers. But now, at least we can do a MoCA testing. Be sure you do your mental exercises. You keep yourself active. The longer you work, it's important you retire, but try to working in something. It's important you do your physical exercise. You do physical exercise, your cognition is good. I try to maintain medications that give you a good cognition. Like I try to use the recycling. ML being here is supposed to be better for that. I want to try to avoid medication for the bladder that sometimes people yesterday were asking me, it's okay for me to take the basic care? I said, it depends. So balance is your incontinence too bad. It is an anticholinergic, it's going to affect your memory. So definitely can affect the memory. So that's acetylcholine. So medications can affect the cognition. You taking medication for depression like amitriptyline, has some anticholinergic effect, can affect your memory as well. So we have to balance risk and benefit, but you don't sleep, you depressed, and the only thing is working, we talk about that. Okay. Most of the time we say, okay, I have pain. I said, oh no, it's not Parkinson's. Guess what? Parkinson's can make you as well having more pain. So you see people have paresthesia. I know paresthesia sensory is your neuropathy, but you think about it, you're more prone to have joint problems and more prone with neuropathies or radiculopathies. In Parkinson's, it's very common to have people having kyphosis or scoliosis, and Parkinson's make it worse. I want to ask you to do an exercise with me. You take one finger and make the finger like this and keep it like that for a second. It's very strong. The longer you keep it like that, you start feeling the pain in the joint. So that's what Parkinson's does in your joints. The rigidity around your joints make you have pain. So that's a paresthesia, burning sensation. We see this is part of the sensory, but is very common in Parkinson's. Okay, let's talk about no motor features. And again, you still have a lot of slides, but I want to slow. This is very important. You have a question, let me know. We have almost a timeout. And it's not only my beginning, but we can continue next time because I think this review is very important. So the no motor features usually can start in late onset or could be the part of the prodromus. When you talk about the no motor, like decrease in sense of smell or constipation, but what are other no motor symptoms? So basically, dementia, again, or dementia could be in the beginning, so that's not typical Parkinson's, it's Lewy body dementia. So about 30%, 3 of the 10 people with Parkinson's in this room can develop dementia. So it's important that you are proactive in the cognition. And usually, when you read neuropsych evaluation, they talk about the visual spatial. So in Parkinson's, the issue with cognition usually is more in the occipital lobe, as well Lewy body dementia. So difficulty with construction, like the cube, the semantic, the building of the phrase or replacing the phrases, difficulty finding words, or episodic memory being decreased. So usually the memory problems increase as you increase your stage in Parkinson's. So that's why from the beginning, only physical, mental exercises. And don't forget, pun intended, you don't have a cognitive test, you think you have a problem with memory, have to do a cognitive test sooner than later. And we talk about hallucinations. So it's almost 2 p.m. We're good in time. You tell me when I need to stop. You okay? Anybody sleeping? Let's do another 10 minutes or so and go for open work questions. So let's stop back down here for some of the mutations of the genetics in Parkinson's. Let's talk about some genes or mutations here. So we're looking about the Parkinson, like your parking lot. There's no park. Park is the genes for Parkinson's. So we thought the PARK1, the PARK8, the PARK17, the PARK22. So you're looking for the mutations here in the PARK1 or PARK4. It's a missense. That's a mutation that has no sense. And so when there is a gene with another gene that makes sense, so they replicate for protein, but there's no sense, then there's a condition. So there could be a duplication or triplication of that gene or that loci. So loci is a place. And look at this. This is a Mendelian autosomic dominant. That means is 50-50. So you have that in your family, 50% in your different generation will have the condition. So you see probably the father, you see somebody, the father or the grandfather or cousin or one sister or somebody else, that not skip any generation. This is what is autosomic dominant. So the PARK4 could be autosomic dominant. Usually, again, I told you right away, I find somebody younger with onset of Parkinson's disease, okay. Family history, okay. Just think about the PARK1. And usually the progression where it is genetic, the progression is faster. How often it is not common. So we talk about the 85% We talked that in the past, but it probably changed and changed. The more you learn genetics, biomarkers probably going to change from 85 to 50, 25. Right now we talk still 85% is idiopathic. That means we're idiots. That means we don't have a reason for that. But the more we learn, probably it's no matter of 85, we probably going to 80. We find more genes. And I told you in the previous lecture that you can, or you are invited to use or participate in the genome and Parkinson's. The National Parkinson Foundation, I think they approached to us like a couple months ago, and they approached the Parkinson's plate that they're doing by themselves. So you thinking about that could be important, especially if your family, you are interested, so your family has a risk, you can have or be testing for your genome or your genotype to see you or your family in risk to have that. Especially you are has descendant for Jewish, the Ashkenazi, or you have somebody in the family with younger onset of Parkinson's, could be advisable. It's very clear you were exposed to pesticides or paraquat, or you went on the Camp Lejeune in North Carolina, or you are a veteran, or now you play golf. That's another thing we had to talk. There's a small article saying that now they here in Florida are more in risk to have Parkinson's because you're close to a golf course. That's is there now. Now our residents getting that. I don't know, Lauren, you guys got the lecture, but one of my residents mentioned that to me, and we talk about in one of the lectures about that. So let's talk about this one, the LRK2 Park 8. Actually, this is a missense mutation. It's autosomal dominant, and we know that's more common in the Jewish, Ashkenazi Jewish population. So it's autosomal dominant. So you Jewish, younger set, we know it's autosomal dominant, so it's better for you to have the genetic testing. So it's lower prevalence. The progression is similar to the typical Parkinson's, but again, it's more common. The only people on that, so it's more common in the Ashkenazi Jewish, and as well in some people from the the Bascos actually, the people from Barcelona, or the Bascos, they want to split from Spain. That's the Bascos. So there was the Basques. So from that, they are a beautiful place in Barcelona, but they're more risk for Parkinson's. Or you are from the north part of the Africa, the Arabian Bar, that can be more at risk to have this mutation. Now let's look for the Park 17. So don't Park 17, as well as missense. And all of this again is autosomal dominant. Again, in the Mendel, you know, Mr. Mendel is the father of the genetics. So Mr. Mendel worked with the small vegetables, and he told them how the cure of the sleeps, and he was there tell us what is autosomal dominant or recessive. So he did a lot of work, and since then we're still using that. So we call autosomal, in the chromosome is autosomal. It's not in the sexual chromosome, it's the autosomal, and the chromosome is dominant. So this one, the Park 817, is autosomal dominant. The clinical features are similar to the typical, and is very rare. Now, the Park 22 is called the CHCHD2. You learned it very easy, right? This missense, there is a split, so the chromosomes on the chromosome split, and then it's autosomal dominant, and it's again, the progression is similar, and as well is rare. You let me know we stop here, we can continue. Let me see if everybody vote. Still awake? We can cut here, we can, okay. Let's do the last slide, and then let's probably have to, I have a lot of slides for it, so we keep the same presentation. It's supposed to be part 2, but it's as good that they have a new season. So we'll be from the next time. So let's stop here. Let's go for questions. I don't want to abuse your time of the residents. So I will be open for questions, and then to be continued. Yeah, so the question is, we talk several for the people in the Zoom. We talk about biomarkers, and we get a biopsy. Yes, we're doing the biopsies now, and will become to be a biomarker. And that's the way we distinguish now. One of the ways we distinguish the typical Parkinson, we have the biopsy here to the neck, versus the multisystem atrophy, which is more peripheral, we use it from the thigh of the ankle. So usually more close to the way you remember, the more close to the nervous system, the central, is the typical Parkinson's. The more peripheral, meaning more the multisystem atrophy, usually is more in the ankle and sometimes the thighs in between. So it's a biomarker. So it basically is alpha-synuclein. But as well, we discussed today about the corticobasal degeneration and PSP not being alpha-synuclein. So in those people, that will be negative. So you do a biomarkers, they have to tell me about the tau. So the tau, again, we have tau in Parkinson's or in Parkinsonism, really, or we talk about tau as well in Alzheimer's. So this is misfold proteins. So we call in the neurodegenerative disease alpha-synucleinopathies, Parkinson's or Parkinsonism. We talk about tauopathies that could be in between the Parkinsonism and corticobasal degeneration, PSP, or tau could be part as well, but a different tau in Alzheimer's. So Alzheimer's is beta amyloid and the tau. We're using a better tau now. So yes, there's a biomarker, and that biopsy not only they tell you about Parkinson's, but tell you have another type of neuropathies or something else. And I told you about the biopsies, not necessarily have to go through your skin. If, for example, you have to have a appendectomy and you have family history, they can do looking for the alpha-synuclein. Or they mentioned in the study we talk in the future, if they do a biopsy of the salivary glands. So you had any tissue can be tell you about alpha-synuclein. So the tissue is the issue, right? It's the skin. So she's asking me about the biopsy. It's a skin biopsy. So this is skin biopsy before we had to send people. So for the people in the Zoom, she's asking me if this is a skin or is the muscle. So the answer is the skin biopsy. So in the past, we sent it to Tampa by one of my colleagues who is a neuromuscular. Dr. Rota is doing in our office. So we're offering, and we have several people already had the biopsy. Basically, it's the skin of the neck, a skin here in the thigh, and a skin in the. So actually, this video, I think, in a previous lecture, I showed you a little bit about the biopsy. It's a punch. It's getting a punch of the skin. Anybody else? Yes, sir. So the question is about essential tremor versus Parkinson's, and if the essential tremor is different, right? So the answer is yes. But again, there's a fine line. Sometimes people can have both. And I explained to you, I found and I realized with this when I tried to review my experience, sometimes I had the feeling, why this patient look essential tremor, but finally we were Parkinson's. And some of them never need the medication. So it's in a small percentage, people with essential tremor had the tremor a little similar to Parkinson's, but I confused by getting better and better on that because you see the tremor is more like the whole arms and more like this, yes, but sometimes it's very difficult. This could be postural and it can confuse something like this, and it's just postural versus pill rolling, that's the typical Parkinson's. So the Parkinson's usually is alpha-synuclein affecting the substantia nigra. The essential tremor is affecting the cerebellum. When I see your pictures of your brain, I explained to you, I showed the pictures, I said they look like a broccoli, that's the shape that the cerebellum has. That's the organ, we call that our small computer, is the area for coordination. So you hit the sixth floor, I ran the sixth floor, you get two people and 100 can get the essential tremor. With age, with age you have tremors. That's the essential tremor, the cerebellum not working well. So you have two things mainly. One is the balance and the action, postural, it's postural and the kinetic tremor, versus the Parkinson's is a resting tremor. So we see, and we review, and we do the review of that article for the essential tremor because it's very important after we finish with the rounds of the Parkinson's, because there's a very nice review about essential tremor. Many people had tremor of the head only, like this. And they had other tremors, that's dystonic tremor. Versus people had the tremor like this, but have a little tremor as well, that's essential tremor. Many times they have tremor of the voice. They have the speech like we call spasmodic dysphonia, but it's like shaking, like he was drunk, or had difficulty swallowing, constipation. This is more cerebellar dysfunction coordination. But having essential tremor places you more at risk to have Parkinson's and vice versa. And some people have both. Or sometimes could be that has some flavor of essential tremor or flavor of Parkinson's, and that be in one of the multisystem atrophies. There is an MSA-C for cerebellum, meaning the main thing looking really like a essential tremor, but has some feature of Parkinson's, and they don't get better with dopamine. So it's not black and white. It's a little more difficult. So the question about the sense of smell, and you know that the sense of smell has been one of the main things in the last 5, 6 years because people with COVID had a lack of sense of smell. And lack of sense of smell, many people with COVID have been developing Parkinson's. So you have decreased sense of smell and stay there is the Parkinson. But you have for no reason, decreased sense of smell could be allergies or something else. You come back, that means it's not the dopamine deficiency. Usually with lack of dopamine, the sense of smell be gone or gone much worse because that's exactly the alpha-synuclein start in the olfactory nerve or start in the vagal nerve and people start constipation first. So that we'll talk in the past, the prion theory, prion for protein and ion for infection. We talk about the theory of being a prion disease. As Attack said, the sense of the smell, then the mesenteric plexus in the abdomen or in the small bowel, and then it's progressed from the vagal nerve to the brainstem. They go to the medulla, and then finally get to the pons, and finally get to the substantia nigra, which are the tremors. And finally, it's continue going up, and then it start having problem with the limbic system. People get depressed, and finally get to the whole brain, and then when people have dementia. That's the natural history of the typical Parkinson's. So, but it's a good question because you don't have decreased sense of smell and the tremor most likely, and then we're thinking about that, most likely is essential tremor, no Parkinson's. This is another board question. Thank you I answered it right, I promise. That's a board question. So the question about drinking alcohol, I don't know if I mentioned this, but we have been talking about alcohol for a long time in Parkinson's, essential tremor, and even dementia. So our recommendation, we see alcohol, and we talk about more in essential tremor, is a fact the alcohol improves the essential tremor. There's no question. And actually, one of the ways we make diagnosis of essential tremor is ask the patient, okay, you have a tremor, take 2 glasses of wine, and then you'll be fine. But the only way you want to work is you need to be drunk. We don't recommend that. And besides that, alcohol after 300 minutes of drinking alcohol with enough, tremor much worse. And then alcohol had the effect in the cerebellum to make it shrink faster. So make the condition being faster and then make you balance even worse. So you'll be more sensitive to imbalance. So the tremor get better, but you get out the floor, oh, and then you fall. Because the alcohol made you balance much worse. So alcohol as well, we don't recommend in somebody with dementia. Alcohol as well, don't recommend people with Parkinson's because sometimes can produce some issue with absorption of B12 or nutrients or malnutrition. So we don't like the alcohol in Parkinson's, dementia, or I'm sorry for that. But we say moderation is fine. Once in a while, actually, for the cardiovascular disease many years ago, they said, one, I don't know what this is, so chauvinist. They said, for male, it's okay to have two, but females, you can have only one. Why? Because you're female. No. So thus, we call about the Mediterranean diet, and they say, suppose that the Mediterranean diet, the alcohol can improve the good cholesterol, decrease your cardiovascular, but we don't have too much evidence now. In the past, we had that belief, but right now, again, we have to go more evidence. So you have a question like that, you always had to go to the National Library of Medicine, look for Medline, and look what study you had to show me that evidence people drinking alcohol versus not drinking alcohol, this benefit or not. You have a sample, or you can write anything in internet. You can say, okay, you are the president of the United States. You read, oh, I believe that. No, people write anything in the internet. So I have to go for the source and look if really there is a serious and give you enough evidence. And that's when you ask something to us, we always go in evidence. Many people ask for a thing for memory or for Parkinson's. I have this gummy that give you dopamine. I don't have evidence. You can spend your money wherever you want, but I don't tell you one way to another, but we don't endorse anything that is not supported by evidence. So that's our answer for that. That answer your question? Okay. Anybody else? Okay, so the question is about the biopsy, when you recommend that. So the biopsy is a biomarker, and it's not like the first line. It's a biomarker. We have a question. Okay, so it is typical Parkinson's, asymmetric, and the person in the front desk, Dr. Gonzalez, one of your Parkinson's patients come, I don't ask for that. This is asymmetric, but it's somebody that does a little bit of the flavor of Parkinson's, or essential tremor, or thinking about now the atypicals, like a multisystem atrophy, then I'll have orthostatic hypotension or multisystem atrophy, we can go there, and they can be better to have evidence that is alpha-synuclein Or looking at that, oh, I don't find alpha-synuclein, but I found that you have a tau. Oh, you probably have a PSP, or you have a corticobasal degeneration. Next, in the next lecture, actually want to show you the difference in MRIs. And actually, you can say the difference in MRIs, we can use another biomarkers beside the biopsy. Biopsy, of course, is invasive. It can produce bleeding, but it's a very good tool we have. And before, in many centers in movement disorder, we use that. Yes, it will be not the last resort, but it's very good and getting better and better, especially with this atypical Parkinson's or Parkinsonism. Any other questions? Okay, everybody's quiet. If anybody want to go home and rest? Yes, sir. Very good. So the question that she's giving how she's experiencing with difficulty swallowing. So, difficulty swallowing is very common in Parkinson's, and definitely that's why we send her for a speech therapy. That works for you, perfect. But again, so he mentioned with some exercises that the recommended YouTube is working. So our recommendation is it's too bad. You can go speech therapy, but definitely some exercises can help you. I tell you some tricks like just place your chin down, place the stroke, but they give some exercise and work for you good. And the coordination. Yeah. So that specific pro you can discuss with the speech therapist, but if that works, perfect, you tell me. But again, the speech therapy can discuss with you what's the best exercises to do. So he's telling for the people in the Zoom that he was very static about the exercises. So very pleased that works for you. So whatever flow you vote and it works, perfect. Okay, any other questions? Okay, thank you for that. And again, going to be step 3. I want to be the Netflix series going to continue with the review for the parking container. I think we spent only like 5 slides. We have a planning project until Christmas. So see you next time. To be continued. Thank you.